hidden away under the ribs. It is a non-complaining organ. The bowel complains a lot. The liver doesn't. So my patients who come in with their chronic hepatitis C, and they say, oh, my liver is giving me all this horrible pain right here. And they, okay, little lesson here. Liver's over here. The liver doesn't cause much pain. They're kind of sheepish as that. Okay, so what we're going to try to do is say, what tools do we have for trying to identify disease in the liver? There are non-specific things. If you look at that list, lots of diseases cause these things. So they're really non-specific. They tell you there's something really wrong, but they don't necessarily tell you what the disease is. Something that's a little more specific is if patients are jaundiced, if they have yellow scleria, if their urine looks like Coca-Cola color, although acute tubular necrosis that you probably learned of in kidney can do that also, or hematuria can. Patients with chronic liver disease can develop ascites, swelling in the abdomen. Rich Mosley will tell you about that. They can develop peripheral edema, but you already know that peripheral edema can be caused by many things. What would be another common cause of peripheral edema? Heart failure. And renal failure requiring dialysis can do it. So some of these are also not very specific, and they really mean the liver is very, very badly damaged, so you're at an end stage. That doesn't help you with early stage. So we're going to talk about several categories of tests that you can use to screen for liver disease. And that's what most of this talk will be about. How can we identify ongoing liver cell injury, problems with bile flow, which is called cholestasis. Then we'll talk a little bit about, do we have any ways of calculating liver function, more quantitative. Then you actually use pattern of liver test abnormalities to start sorting liver disease into groups. And this is a lot easier than diarrhea, I promise. Finally, there's diagnosis of specific liver diseases. The other lectures you're going to hear in the next couple of days will talk mostly about those. So how can you tell that liver cells died or were injured? Transaminases, which many people call liver function tests even though they're not, or liver enzymes, are two enzymes, alanine aminotransferase, aspartate aminotransferase. Now, what are these? Well, they have a normal function in the liver. They're used for transferring amino groups from one amino acid to another or to make amino acids. That has nothing to do with their role as liver injury tests. They just happen to be there in very large amounts. They're easily measured, and ALT is very specific for liver. AST is also in muscle, just to make life confusing. So again, ALT is liver only. It's in the cytosol. AST is in other tissues, although the liver has a huge amount. In the cytosol, there's a mitochondrial fraction. Now, depending on the method your laboratory uses, there is a normal range. The old normal ranges used to go up to 70. Now in most labs, they're down to about 30 or 35 because the methods were changed a little bit. And we realized that some of our normal population wasn't all that normal. There's always some in your blood because liver cells turn over. They don't survive forever. They're long-lived, but they die. So there's always some. Another fact that we will talk about later is that they require a B vitamin, pyridoxal 5-phosphate, as an essential cofactor, and that works into a few little interesting clues you can use to look at alcoholic liver disease. So these are easily measured in our automated systems in the lab. You throw the serum with a substrate into a little tube, and it runs through, and a colored product is developed, and you can measure that with a photodetector, and then you can change that absorbance or light to enzyme activity. So what the lab measures is the enzymatic activity of these, not the protein. And there's no DNA here, so molecular biology's out. So this is my crude drawing of a liver cell that gets injured. And here's the biocanalicular. You got mitochondria, you got a nucleus, you got AST in several places, you got ALT in the cytosol. When the liver cell finally ruptures, These things can get directly into blood because you've got that nice fenestrated endothelium. So they're easily detectable in blood. They're convenient. There's a lot of it in the liver. It directly gets released into blood. So you can really, this is a very sensitive and relatively specific measure of ongoing cell injury. So I kind of joke that it's telling you how many liver cells died in the last 24 hours. Because these enzymes are then cleared by the reticuloendothelial system or other things. They don't tell you how many liver cells died 2 weeks ago. They don't tell you how many are going to die tomorrow. They told you what injury is going on right now. And so you can look at patterns in different diseases. Diseases that kill a lot of hepatocytes in a fairly short period of time are going to have much higher levels of this in blood at any given time than people who have a disease where there's only a little bit of damage occurring. Doesn't tell you about duration of disease. It tells you how much injury. So if I give you a severe attack of acute viral hepatitis and you're really sick and a lot of liver cells are dying every day, you're going to have values in the thousands. It can even be 5,000. If you have a much milder disease clinically, that usually means a lot less cells are being killed at any one time, you're going to have a lower level. Hepatitis C, which you'll hear about tomorrow and next week, is a virus that causes a low-grade chronic injury. So on a day-to-day basis, you have a very low level of these enzymes. Now, this is a disease that over years can cause cirrhosis, but on a day-to-day basis, the injury is low. If somebody already has a lot of scar tissue in their liver, but the underlying disease that caused that is gone or damped down, you may have normal values because there's no injury happening today. Okay? So this is back to the liver I showed you before. This person necrosed a third of their liver in the last 24 hours. Are they going to have really high transaminases or really low? Really high. This may be 10,000, 20,000. Doesn't last for very many days, but while it's there, it's really amazing. Now you have to consider that AST is also found in other tissues. Muscle is a big one. So if you go out and get in a motor vehicle accident and your right leg is crushed, your AST level may be very high, but the ALT should be much lower because you've crushed muscle. Muscle has a lot of the AST, but it doesn't have very much ALT. And these are very sensitive tests in that even a little bit of liver injury can cause these to go up enough to be detectable. So here's a patient with a fatty liver. You've got nice hepatocytes. Some of them have little globules of fat. Some of them have these big globules. This person may have an ALT and an AST that are 1.5 times the upper limit of normal. If normal is 35, it may be 42. And you don't really see any liver cell death there because there's very little injury happening. It may be just an occasional hepatocyte in the whole liver. Okay? But it's still telling you there's something going on in the liver. Okay. So the problems using the transaminases are that it only tells you what's happened in the last day or two. And if you have a disease process that kills cells by apoptosis, it may underestimate the image because those cells are collapsing inward and they're not releasing as much. Turns out that's not a big problem for us, but it's there. And it doesn't tell you what's happened to liver function. Liver function depends on how many remaining good hepatocytes you have. Now, if I tell you somebody has had an AST and an ALT of 10,000 for each of the last 17 days, they've probably got bad liver function. By that time, you may have wiped out 90% of the liver. But that's giving you an additional piece of information. It's duration. Okay? So the magnitude on any one measurement doesn't tell you the degree, how much function is left. Okay. So if you think of them as the rate of destruction of hepatocytes. Liver function is the number of functional hepatocytes left. The liver is a mass. Okay. So not all liver abnormalities cause liver cell death. This is a CT scan of a liver with contrast, and you see this big black hole here. Well, that's a benign cyst. It's a fluid-filled ball with an epithelial lining that looks like bile duct cells. It's probably been there for the last 10 years. It's not doing anything. It's not changing anything around it. This person will have perfectly normal liver injury tests. Now, this is actually a completely benign process. It's pretty common, so it's not a disease either. But patients hear about this when they get a scan, and they want to know what it is and if it's going to kill their liver and things like that. So we have to explain it. Now, I want to give you one little interesting twist, and I can guarantee when you're on a medical service and you admit a patient who's an alcoholic with liver disease, somebody will ask you this question. So there's an interesting twist on the pyridoxal 5-phosphate story that helps us get a clue to alcohol causing liver damage. These enzymes both require pyridoxal 5-phosphate, B6, as an enzyme cofactor. A lot of alcoholics are deficient in this. It's a water-soluble vitamin. You don't have a body store for it. They're getting most of their calories from alcohol. We have talked about, shouldn't we be fortifying all alcoholic beverages with B6, but nobody's ever done that. And so they can become deficient. When you're deficient, first of all, the liver doesn't make as much of these enzymes, so there's not as much there, and you have very low enzymatic activity. The protein may be there, but it doesn't work. And what the lab measures is how well these enzymes work. So, and finally, there's also this twist about the mitochondrial AST. Alcohol shifts that off to the plasma membrane. It gets out into blood more easily. So when you have a patient who's drunk a lot of alcohol and has alcohol-induced liver injury, you have more AST than ALT released into blood from the damaged hepatocytes. Both of them, though, are not very enzymatically active. And so you end up, and this is, again, my little diagram. Normal, you've got the enzymes, you've got the cofactor, they're working really well, they're easily measured. Alcohol, you don't have as many, they don't work. So in an alcoholic, when you are looking at AST and ALT in the blood, for the same amount of liver cell injury, these levels are going to be lower, but you're going to measure more AST than ALT. All right. And so the ratio between AST to ALT is shifted. Normally, when you have liver cell injury, you get a little more ALT than AST. In alcoholics who are pyridoxal 5-phosphate deficient, you get the inverse ratio. So a ratio of 2 to 1 or more is a clue that this could be alcohol-induced liver injury. You also tend to have lower levels for any given amount of liver dysfunction or injury. So we often underestimate how much liver cell damage is going on because these tend to be artifactually low. Okay. So a high AST to ALT ratio, especially if both of them are kind of low, think alcohol as the cause of the liver disease. And remember, you may be underestimating the amount of liver injury. Okay, so that's how you tell liver cell problems. I'm now going to switch to problems with bile flow because there are diseases that primarily or predominantly affect bile formation and flow before they affect all the liver cells. Those are called the cholestatic diseases. And the enzymes that really go up with this is one called alkaline phosphatase and some related enzymes, and I'll show you why. If you have bile flow that has been blocked completely or almost completely, then things that are excreted in bile go up in the blood as well, and these patients get jaundiced. But that's a later phenomena, a more severe process. Alkaline phosphatase goes up early when you have mild impact on bile formation. So alkaline phosphatase is actually located, it's a membrane protein. It's on the canalicular membrane. And so you see these squiggly little lines of the stained alkaline phosphatase between the hepatocytes, whereas here is a sinusoid. And it's an apical membrane protein. It's very sensitive to changes in bile flow. It's amplified by retaining bile acids if bile flow isn't going well. And it's easily released into blood because it's a GPI-anchored protein. It is not a transmembrane protein. So it can be solubilized out of membranes by bile acids. It's easy to measure spectrophotometrically. Now, hepatologists have been able to measure this for decades. We know it's a great clue. We use it all the time. We have no idea what it does. It's called alkaline phosphatase because it takes phosphate groups off various things on an alkaline pH. But we have no idea of its normal function. Recently, there's been some speculation that it actually it detoxifies lipopolysaccharide, LPS, from bacteria. But we don't know if that's its major function or not. So I haven't a clue. Its synthesis goes up when the liver retains bile acids. So when you can't excrete them all and you get more of them stuck in the liver makes a lot more alkaline phosphatase. This is just an example of cells in tissue culture exposed to varying amounts of alkaline phosphatase, and you can see their production of it goes way up. So that helps to amplify the signal. That's why this is probably such a sensitive marker. Another thing that retained bile acids do is they're detergents. They can solubilize pieces of membrane off hepatocytes. Here's an isolated hepatocyte. It's more of a ball. It's got also microvilli. You throw in a bunch of bile acids and you start getting all these pieces of membrane being shed. Well, that membrane has alkaline phosphatase on it. Helps get it out into blood. So here's another picture of our two hepatocytes. The alkaline phosphatase and these other GPI-anchored proteins like 5' nucleotidase and gamma-glutamyl transpeptidase are on the apical membrane, but they get solubilized off, they get amplified, and they go out into the blood either as single enzymes or attached to bits of membrane. Okay. So what's the pattern of alkaline phosphatase elevation? Well, the longer you've had bile obstructed and the worse the bile obstruction is, the higher the alkaline phosphatase. So somebody who's had a complete obstruction of their common bile duct for 3 or 4 or 5 weeks, and they're going to be jaundiced, will have an extraordinarily high alkaline phosphatase. It takes a while to get the alkaline phosphatase made and released. So if I tied off your common bile duct today, you would maybe have a little bit of increase in your alkaline phosphatase tomorrow. It takes a while to go up. So an acute bile duct obstruction may have a much more trivial elevation, but it will be elevated. It will keep going up. If it's very early, it may be close to normal. Now, you also get alkaline phosphatase released in hepatocellular disease. If you destroy hepatocytes, they will release some alkaline phosphatase. So a bad viral hepatitis, you still have a little bit of alkaline phosphatase elevated, but it's not nearly like the amount you get from a cholestatic disease. So alkaline, yeah?
Does the canaliculi have to be, the integrity of the canaliculi, does it have to be disrupted for alkaline phosphatase to be released?
No, some of it's probably released by mistranslocation to the basolateral membrane, but when bile flow doesn't occur, those tight junctions can get disrupted pretty easily. So it's fairly easy for things on the canaliculus to get into blood. So when you see an elevated alkaline phosphatase, the differential diagnosis is diseases that block bile flow. You can also get it if you have disease infiltrating in the liver that's pushing hepatocytes aside. Not diseases that are destroying hepatocytes, but diseases that are pushing hepatocytes aside. And I think that's because you're getting compression of a lot of the little bile canaliculi and the very small intrahepatic bile ducts as well. So it's a sensitive test. If I tie off one bile duct way over in the left lobe of your liver, your alkaline phosphatase will go up. It's only coming from that one area because the cells behind that are making alkaline phosphatase like crazy. They're very unhappy. The disadvantages are it's not specific. There are isoenzymes. But the other disorders can be pretty readily identified. Most people, well, first of all, only half the world can get pregnant. And secondly, many people know they're pregnant. So that one can be identified. Intestinal obstruction, you're coming in with a bad obstruction of the bowel. People are going to make that diagnosis. They're going to take care of you. It's not really an issue. Bone disease is the other one. So if you see a mild or moderately elevated alkaline phosphatase that's persistent, you have to think, is this from bone rather than from liver? You can actually fractionate it, and the lab can tell you, is it primarily bone or primarily liver? So if somebody has a healing fracture, their alk phos is going to go up while it's healing. If you have metastases that are destroying bone, alk phos can go up. If you have a disease called Paget's disease, where bone is hypertrophying rapidly, you can have an elevated alkaline phosphatase. But those are really isolated problems. They're not usually an issue here. We have to at least think about that. So the other things that you can look at that give some hints to problems in bile flow, but they're more for end-stage bile flow problems, are bilirubin and bile acids. Bilirubin was our first test for liver disease because you could look at a patient and see they were yellow. And the rationale is the liver is the only mechanism for excretion. If you have blocked bile flow, then it backs up into blood. Now, but that can also occur if you have really bad liver failure. If your hepatocytes are all dead, they're not going to get rid of the bilirubin either. So you have to look at the liver, you have to look at the whole picture to separate that out. Bilirubin is an organic anion. It's a byproduct of heme breakdown. It has to be conjugated to glucuronic acid, and blood levels go up if production or excretion are altered. However, to get bilirubin to go up in blood to any significant amount, you really have to almost completely block all bile flow. So the worst jaundice is when the common bile duct is obstructed. That's like tying off the Mississippi River at the Delta. Everything upstream doesn't work. If you tie off the Ohio River, it's not going to affect flow of everything else down the Mississippi. So again, we have the picture I showed you before about how bilirubin comes in. It's conjugated in the smooth endoplasmic reticulum, goes out by this ATP-dependent pump. Not the same pump that handles bile acids. So we have a jaundiced patient and his non-jaundiced twin brother. And if you look at the sclerae, they're bright yellow, and the skin has a yellowish cast. Of course, that does depend on how you set the filters on your camera or whatever. So how can you get problems with bilirubin handling? You can produce too much bilirubin from hemolytic anemias, and you'll learn about that in hematology. If you're breaking down a lot of red cells quickly, you produce a lot of bilirubin. It has to get to the liver. And if it's a lot of red cells broken down very, very quickly, you can get so much bilirubin it can't be handled right away, and the bilirubin level in the blood goes up, and that's unconjugated. The next step is the conjugation step, where glucuronic acid, a sugar group, is hooked onto it. There are diseases that can cause a problem there. They're genetic. The rare one is Crigler-Najjar. You don't have that conjugating enzyme at all. You have a severe unconjugated bilirubinemia from birth. If you're lucky, you don't get brain damage at birth. It's tricky to handle that one. The common one, which probably 10% of you have, is called Gilbert's syndrome. It was a Frenchman. That's why it's Gilbert and not Gilbert. That is a mild defect in conjugation. so that bilirubin is just conjugated at a slightly slower rate. And people can have a little bit of unconjugated bilirubin in their blood. They don't really get jaundiced, but it can be picked up on the lab tests, and somebody wants to know, why is my bilirubin 1.5 instead of 0.9? If you fast somebody with Gilbert's or you give them a fever, their bilirubin can really go up enough that they can be jaundiced. But it's all unconjugated, and the lab can tell you whether this bilirubin is conjugated or unconjugated. Then there's diseases of this transporter. There are some genetic disorders, they're very rare, where you have a total absence. These folks will be very deeply jaundiced from birth, but because the bilirubin's conjugated, they don't suffer brain damage. They're just really, really yellow. Then there are drugs, and we'll talk about that on Friday, like estrogen, that can slow down this transporter, and you can get a problem with that. Obviously, if you destroy the liver cells, you're going to get jaundice as well. Once you can't get rid of it here, this is the rate-limiting step. The extra conjugated bilirubin refluxes back out into blood, and that's why you get bilirubin in the skin and the tissues and the sclera, and some of it goes out in the urine so that you do have some dark urine. It can also bind to albumin, and it can form a covalent bond there, so it may clear very slowly after you've resolved the medical problem. So the interpretation of elevated serum bilirubin is that bilirubin, if it's conjugated, bilirubin reached the liver, it got conjugated, it didn't get excreted. So you either have a problem in bile flow, or you have the liver not working well, or a combination, and there's these rare genetic disorders or drug-induced disorders that can't let go of secretion. Unconjugated bilirubin means you have a massive overproduction, or you have some defects in the conjugation step. And I told you that in prolonged conjugated hyperbilirubin, the conjugated bilirubin with glucuronide can stick to albumin and circulate for weeks so that this bilirubin may clear very slowly after you resolve the problem. And it's not really, it's there, it's not of interest during liver disease, but it can be a reason why that you relieve the obstruction in someone and their bilirubin isn't falling very rapidly. You can reassure everybody it's okay. This is going to take a while because some of it's stuck to albumin and it's going to take a while to go away. So I wanted to then talk about quantitative tests of liver function. How can you tell if the liver is not functioning well? So you can do several things. The liver produces stuff, so you can look at blood levels of things that it produces. And that's actually what we do. We look at albumin and clotting factors. You could look at rates of elimination of things like bilirubin and bile acids, but we don't have an easy way to do that. We're not cannulating the bile duct and infusing things and looking at clearance. There have been attempts to look at metabolism by giving radioactive or otherwise tagged compounds that are broken down in the liver, like aminopyrine, releasing a labeled carbon that then goes out in the breath as carbon dioxide. But this uses radioactivity. It's very clumsy to use, and it never really caught on. It's too clumsy and test, and it didn't give us any additional information. So we're stuck with albumin and the prothrombin time. So the rationale for albumin, the liver is the sole source, and if you don't have enough liver cells, you don't make it. However, you have to remember that if you're losing albumin somewhere, the albumin level will go down. So nephrotic syndrome, loss of a large amount of protein in the urine from diseases that cause nephrotic syndrome will cause a low albumin. Similarly, there are some inflammatory bowel diseases where you get a lot of protein lost in the bowel. It's not very common, but it does happen. Finally, if you're malnourished, protein malnutrition, calorically deprived, the liver decides to save its resources and it shuts down albumin production and focuses on other things. And albumin level in chronic malnutrition may be quite low. In addition, in very severe inflammatory states, sometimes the liver decides not to make as much albumin. Now, it's got a very prolonged half-life. So it doesn't tell you what happened to the liver in the last week. It tells you how the liver's been functioning over the last couple of months. So it gives you a global look at liver function over a period of time. If I whack out your liver today, your albumin tomorrow will be normal. There'll be a lot of other things wrong, but your albumin will be normal. So remember, it tells you a long-term look. Prothrombin time, the liver is the sole source of vitamin K dependent factors. Factor 7 has a very short half-life, so this changes quickly. Clearly, the interpretation, however, is different things. It can be liver failure, but you also have to remember, is this patient vitamin K deficient? Are they on Coumadin? Do they have disseminated intravascular coagulopathy? You can usually figure those out. You just have to remember that they're possibilities. It's very nice because it changes quickly, so it can tell you if there are rapid changes in liver function, which is great in an acute liver disease. So what these tell you is that lots of liver is gone or non-perfused, and your reserve function, because the liver, like all organs, has reserve, that's gone. And you're down to less than the core amount of necessary functional hepatocytes. Albumin monitors slow and long-term changes. ProTime can tell you rapid changes, but it'll also be abnormal with long-term liver dysfunction. Other clues to globally impaired liver function, bilirubin, but it goes up if you just have bile duct blockage. So it's not terribly specific. Glucose with hypoglycemia, it's a very late finding. Only when the liver is really almost completely gone does that go up. BUN, not great, because the kidneys can also make urea, and there's some variation. It depends on how much protein you're eating. But our end-stage cirrhotic patients who have a really bad liver often have a very low BUN. So the way you apply these is pattern recognition, to try to separate liver diseases into different categories and think about, is the liver functioning? Is it not functioning? Is this hepatocellular disease? Is it cholestatic disease? Is the liver functioning? That's what I'm going to spend the last few minutes on. So anytime you see abnormal tests, always think, is this coming from the liver? Is it something else? Then look at the pattern, cholestatic versus hepatocellular. Is there anything that tells you this may be acute versus chronic? Is the liver function bad? Is the liver function still pretty good? All right. So to tell whether it's hepatocellular or cholestatic, you look and tell whether the main abnormality, the biggest change, is in the transaminases or in the alk phos. They may both be abnormal. So look at the amount of difference, the number of times the upper limit of normal. If this is 10 times the upper limit of normal and this is 2 times, I'm voting on a hepatocellular disease. If this is 10 times the upper limit of normal and this is twice the upper limit of normal, I'm going to go with a cholestatic disease. These other things are not in and of themselves specific enough to tell you for sure. But if you look at a bunch of them and they're a little jaundiced, but there's a lot of ProTime abnormality, I'd go more for hepatocellular. But it's these two that you should focus on. So if you have a viral hepatitis, for example, an acute viral hepatitis, you're likely to have a much higher transaminase related to alkaline phosphatase. This is how many fold the normal limit. Now your bilirubin, whereas if you have tied off the common bile duct, your transaminases won't be very elevated, but the alk phos will be much more elevated. Depending on what's happened to bile flow, they can be similar or radically different. Hepatocellular tends to knock out the ProTime earlier because you're destroying hepatocytes first. But it's the comparison of these two that are the most useful. Clues to acute versus chronic. Well, history, there are other things that may tell you, but just looking at the liver tests, look at the protime and the albumin. If they're both normal, you don't know. You don't know whether it's a mild chronic or a mild acute. But if they're abnormal, you can look at them and say, am I seeing chronic or am I only seeing something that's very acute? So you can also look for clinical signs of long-standing liver disease. You can look for, if you know over time they've had this, that can help. But the abnormalities of protime versus albumin can get you started. So in a chronic disease with impaired liver function, you'd have elevations in the enzymes, could be highly variable, but if the liver's not working, you're going to have high bilirubin, you're going to have an elevated prothrombin time, and if this has been going on for a long time, the albumin will be low also. If you have an acute liver disease, then you may have the protime up, but the albumin may still be normal. So how can you get clues to severity in terms of function? Prothrombin time is your best short term. Albumin can help. And some of these other things can feed in as you learn more about liver disease, but I would look at these two first. You can also look at the time course of changes. If the transaminases are rapidly rising and getting very high, this is a rapidly moving, severe, acute disease. More slow elevation to a lower level, it's a more mild, it may still be an acute disease. A rapidly falling transaminase when they've been very high is not necessarily a good thing. You may have run out of hepatocytes. That means if you don't transplant this patient's liver, they're probably going to die in the next 2 days. So a rapidly falling one can be the disease is getting better very quickly, but it can be you've run out of hepatocytes. So then look at the function. In this one where they had very high levels of transaminases that rapidly fell, you've got a rapidly rising prothrombin time. That tells you you've wiped out all the liver cells, your function is very bad, this person needs a different liver. Diagnosis of specific liver diseases, we're going to talk about those in future lectures. So in summary, you use biochemical tests to detect presence of liver disease, try to categorize it into cholestasis or hepatocellular, see if you can get a sense of whether function has been impaired, and if so, does this look like it's acute or chronic? And then use them to then tell you clues as to what diseases to look for. And I've got some examples of liver tests in your syllabus. I'll have some in the problem solving later this week to help you work through the interpretation. These are tests you can get in 6 hours from the lab. You can actually mine a lot of information from it. Okay, so we will see you tomorrow.